Hi, everyone. It is my pleasure to talk in WFUMB 2022 Congress in Romania. This time, I would like to share my thoughts about Nutcracker phenomenon and Nutcracker syndrome. Specifically, I want to share my belief that we have investigated too little and neglected too much about this phenomenon and this syndrome. After I retired from the Seoul National University Hospital, I have been working with two fellow nephrologists in a kidney specialty clinic, and we are taking care of many patients with proteinuria or microscopic hematuria, which was found at a routine healthcare checkup program. I do kidney ultrasound and check left renal vein in every patient, and I found a lot of those patients have Nutcracker phenomenon. Many of those patients with Nutcracker phenomenon did not have any other causes of proteinuria or hematuria, and so can be diagnosed as Nutcracker syndrome. But we should know that Nutcracker syndrome has been thought rare and is registered as a rare disease in NIH and orphanet sites of the United States. So a big question I had was really how common or how rare is this syndrome? And I decided to investigate the incidence of this phenomenon and the syndrome in my clinic. And I wanted to understand how important is the syndrome to the patients? In other words, how serious do these patients consider their cause unknown proteinuria or hematuria? And I also wanted to understand what we know and what we do not know about this phenomenon and syndrome. Nutcracker here we are talking about is not this kind of nutcracking, but this using this two-armed metal device. Nutcracker syndrome is caused by the compression of the left renal vein between the abdominal aorta and superior mesenteric artery, which causes left renal vein hypertension that may result in hematuria, proteinuria, left flank pain, or various other symptoms or signs. The name of this condition, Nutcracker syndrome, was first used by Dr. De Schepper, a Belgian radiologist in 1972, describing the similarity of this condition with a nut in the space between two arms of a nutcracker. Historically, in 1970s and 80s, when ultrasound or CT was not popular, and also regular health checkup were not popular, the diagnosis of the Nutcracker syndrome was done in patients with gross hematuria by demonstrating compression of left renal vein with an invasive catheter venography and measuring pressure gradient more than 3 millimeter mercury across the site of compression. I had a special interest in the diagnosis of this syndrome with Doppler ultrasound, and this is an article I wrote in 1996 in Radiology. The normal peak flow velocity of the hilar left renal vein is 10 to 20 centimeter per second, while it is 40 to 50 centimeter per second at aortomesenteric portion of the left renal vein. This difference of flow velocities in hilar and aortomesenteric areas indicates normal, natural, and subtle compression at aortomesenteric left renal vein. To prove usefulness of Doppler ultrasound in the diagnosis of Nutcracker syndrome, we compared the peak flow velocities in Nutcracker patients and control groups. And we reported that if the peak flow velocity of the aortomesenteric left renal vein is higher than 80 to 100 centimeter per second, which is twice the normal 40 to 50 centimeter per second, we may make a diagnosis of a Nutcracker syndrome. In addition to the velocity information, color Doppler ultrasound may show bright-colored, high-velocity jetting phenomenon through the compressed and narrowed aortomesenteric left renal vein. This is a young woman with gross hematuria. Grayscale ultrasound shows compression of the left renal vein between the abdominal aorta and superior mesenteric artery, and color Doppler shows bright-colored high-velocity jetting, and the measured peak flow velocity was 138. And there was no other cause of hematuria, and so the diagnosis of Nutcracker syndrome was made. Here, we need to be clear in the difference of two terms, Nutcracker phenomenon and Nutcracker syndrome. Nutcracker phenomenon is just a phenomenon of compression of the left renal vein between two arteries, while it is called Nutcracker syndrome when the phenomenon is accompanied by otherwise unexplainable symptoms or signs, such as hematuria, proteinuria, left flank pain, or other related symptoms. These three numbers explain how commonly I found Nutcracker phenomenon and syndrome among the 1,223 consecutive patients who were examined with Doppler ultrasound in my clinic. Among these 1,223, 372 showed Nutcracker phenomenon with higher than 100 centimeter per second peak flow velocity in aortomesenteric left renal vein. And 184 of those 372 with the phenomenon were Nutcracker syndrome patients because they had symptoms and signs that cannot be otherwise explainable. Again, about 30% of total showed Nutcracker phenomenon, and about half of those patients with the phenomenon, in other words, about 15% of total could be diagnosed Nutcracker syndrome. Based on these data, I'm sure that Nutcracker phenomenon and syndrome are not rare, but are quite common. One question you might have is, what is the relationship between Doppler velocity criterion of 80 to 100 centimeter per second and the pressure gradient criterion of 3 millimeter mercury? If we calculate theoretical pressure gradient using this Bonnet principle, this velocity criterion of 80 to 100 centimeter per second is equivalent to pressure gradient between 2.39 to 3.81 millimeter mercury, which is quite consistent with the 3 millimeter mercury pressure gradient criterion. So we may use Doppler ultrasound with the velocity criterion without invasive venous catheterization process in the diagnosis of Nutcracker phenomenon and Nutcracker syndrome. This is a 66-year-old man with microscopic hematuria. Color Doppler ultrasound well shows bright-colored high-velocity jetting through the aortomesenteric left renal vein, and peak flow velocity was 143 centimeter per second. And the estimated pressure gradient is approximately 8 millimeter mercury. Because there is no other cause of microscopic hematuria in this patient, the diagnosis was Nutcracker syndrome, and we do not need invasive venous catheter procedure to measure pressure gradient in this patient. The classical Nutcracker syndrome usually occurs in a young and thin, previously healthy people with a small amount of retroperitoneal fat and the prominent lumbar lordotic curve like this body shape, but it may occur in other body types also. We did not know this well. Also, in the classical Nutcracker syndrome, left renal vein is compressed in the narrow space between the abdominal aorta and superior mesenteric artery. But there are at least two more subtypes where the space between the abdominal aorta and superior mesenteric artery is not narrow, but left renal vein is compressed by other mechanisms. We didn't know that. This is a classical type 1 Nutcracker. In the second type, left renal vein is compressed by the origin of the right renal artery, which is arising slightly anteriorly. And in the third type, left renal vein is stretched over the abdominal aorta. Type 2 nutcracker is very common, and type 3 nutcracker frequently occurs in old patients with tortuous abdominal aorta. This is a classical type 1 nutcracker in a young, slender woman with a long history of proteinuria. Hilar left renal vein is dilated and aortomesenteric left renal vein is tightly compressed between the abdominal aorta and superior mesenteric artery. And bright-colored, high-velocity jetting is well seen in color Doppler ultrasound, and peak flow velocity is very high, 230 centimeter per second. Another type 1 nutcracker in a young slender man with proteinuria and fluctuating glomerular filtration rate. Aortomesenteric left renal vein is tightly compressed in the narrow space between the aorta and the superior mesenteric artery, and the color Doppler ultrasound shows absent flow signals in the dilated hilar left renal vein, indicating stagnant flow, and the peak flow velocity was 182 centimeter per second. In the severe nutcracker syndrome like this patient, glomerular filtration rate can be very different according to the time of blood sampling. This is an asymptomatic woman with type 2 nutcracker phenomenon, and the left renal vein is compressed by the right renal artery with bright-colored jetting from the side where left renal vein is compressed by the right renal artery with peak flow velocity 165 centimeter per second. A young woman with proteinuria. Grayscale ultrasound shows compression of the left renal vein between the abdominal aorta and superior mesenteric artery, and also posteriorly by the origin of the right renal artery. But color Doppler ultrasound shows bright-colored jetting from the site where left renal vein is compressed by the right renal artery. So type 2 nutcracker with peak flow velocity 177. This is an old woman with hematuria and cystitis-like bladder symptoms. Ultrasound shows left renal vein stretched over the aorta and bright-colored jetting flow from the site where left renal vein is narrowed anterior to the aorta, and peak flow velocity was 148. Another old asymptomatic man with similar type 3 nutcracker. Abdominal aorta is slightly dilated and the left renal vein is severely stretched and narrowed over the aorta with jetting flow and 168 centimeter per second peak flow velocity. In some cases, Nutcracker shows findings of different subtypes according to the phase of respiration. This is an example, a 56-year-old asymptomatic woman, and ultrasound shows sluggish flow in the dilated left renal vein, bright-colored jetting flow from the aortomesenteric portion, and peak flow velocity was 180 centimeter per second. If we look at the narrowed left renal vein more carefully, it has different patterns of compression during the respiratory cycle. Type 1 pattern, now compressed between the aorta and superior mesenteric artery, and now type 2 pattern, now compressed by the right renal artery, and now type 3 pattern are stretched over the abdominal aorta. This case well shows that Nutcracker phenomenon is not a fixed condition, but a dynamic and changing conditions during a respiratory cycle. Also, Nutcracker is a dynamic phenomenon with postural changes of the patient. Ultrasound is an excellent modality that can illustrate the difference with postural changes. A young woman with microscopic hematuria, proteinuria, and left flank pain. In supine position, typical type 1 nutcracker with a very high peak flow velocity, 214 centimeters per second. Superior mesenteric artery is here. When the patient takes left lateral decubitus posture, superior mesenteric artery moves to the left side and the left renal vein compression is relieved and the peak flow velocity decreased to 51.7 centimeters per second, a normal value. And when the patient takes right lateral decubitus posture, superior mesenteric artery moved back to the pre-aortic location and the left renal vein is again tightly compressed between the aorta and superior mesenteric artery, and again with very high peak flow velocity, 220 centimeters per second. She told me that her usual sleeping posture was right lateral decubitus, and I explained about Nutcracker syndrome and about the changes of Doppler findings with different postures, and recommended her to change her sleeping posture from right lateral decubitus to left lateral decubitus. And she came back to my clinic 1 week later with a bright smiling face and told me that her flank pain disappeared. This case well shows the ability of well-performed Doppler ultrasound examination in the diagnosis and also management of a patient with Nutcracker syndrome. Another similar patient, 60-year-old woman with microscopic hematuria and low abdominal pain. Doppler ultrasound shows a similar difference of movement of superior mesenteric artery and a similar difference of left renal vein compression according to the postural changes. And her best sleeping posture will be left lateral decubitus again. But in some patients like this, 32-year-old woman with proteinuria, the movement of the mesenteric root containing superior mesenteric artery is limited, and the degree of compression of the left renal vein is similar in supine left lateral decubitus and right lateral decubitus postures with similar peak flow velocity, 177, 132, and 178 in this patient. Probably this finding of limited variability of Nutcracker with postural changes indicates adhesion or fixation of the mesenteric root. We need to investigate further about Nutcracker with this limited movability of mesenteric root with postural changes. Here is another patient with limited movability of mesenteric root and a similar degree of Nutcracker phenomenon with a similar jetting phenomenon in 3 different postures. Here is another example of limited movability of mesenteric root and a similar degree of Nutcracker phenomenon with similar sluggish flow in the dilated left renal vein in 3 different postures. CT scans are commonly used as a primary imaging study in patients with hematuria, and early phase contrast-enhanced images show movement of contrast-opacified blood of the left renal vein into the inferior venous cava. We usually did not pay much attention to these findings, but it has important information indicating the velocity of left renal vein flow. We may divide patterns of left renal vein flow into these 4 categories. Number 1, plug flow pattern. Number 2, flow of heavier contrast-opacified flow along the posterior dependent margin. And number 3, flow of contrast-opacified blood along the anterior non-dependent margin. And number 4, jetting of flow through the narrowed aortomesenteric left renal vein. These pattern 1 and 2 indicate relatively slow flow and pattern 3 and 4 indicate relatively fast flow. This is an example of pattern 3 flow, and this is an example of pattern 4 flow, jetting pattern. If you pay attention a little bit when you are reading CT scans of patients with hematuria or proteinuria, you may easily have an impression about these flow patterns. And if it is a pattern 3 or 4, you may recommend Doppler ultrasound for diagnosis. These findings of Nutcracker SCT have not been known well, and we need to investigate further. The last thing I want to mention is how seriously these patients consider their cause of non-hematuria or proteinuria. This is a 28-year-old woman who was found to have proteinuria from her childhood for 20 years without any explainable cause for her proteinuria. Ultrasound shows type 1 Nutcracker with peak flow velocity 147 centimeters per second. Her kidneys looked normal, and she was told that her proteinuria was likely due to the Nutcracker phenomenon. Not to worry much about her proteinuria. Take left lateral decubitus sleeping posture and just take it easy and follow up. She told me that during the past 20 years, she and her family worried about her proteinuria so seriously and thought she eventually may need dialysis or transplantation. A 46-year-old woman with microscopic hematuria, proteinuria, and low glomerular filtration rate, and she worried about her kidney status seriously. She visited several hospitals without any diagnosis and visited my clinic. Ultrasound shows type 2 Nutcracker phenomenon with peak flow velocity 178 centimeters per second. I explained her about Nutcracker syndrome, which is probably the cause of her hematuria, proteinuria, and abnormal glomerular filtration rate, and recommended her to take left lateral decubitus sleeping. Follow-up glomerular filtration rate was normal, and she expressed her feeling when she heard about her Nutcracker syndrome that it was something like a cancer diagnosis she heard was a mistake. Her expression well shows us how heavily she was pressed psychologically by her cause unknown hematuria and proteinuria, and how strongly ultrasound diagnosis of Nutcracker syndrome relieved her psychological pressure. We need to understand the importance of imaging diagnosis of Nutcracker in helping our patients with Nutcracker syndrome physically and psychologically. This is my website for educational, clinical, and research contents, and many patients with hematuria, proteinuria, or abdominal pain visiting my clinic already have quite extensive information of Nutcracker from my website. I will show you an example case. This was a 36-year-old man with proteinuria and left flank pain. He saw my website and thought he might have a Nutcracker syndrome. Ultrasound shows Nutcracker phenomenon with high velocity jetting with peak flow velocity 141, and we could make a diagnosis of Nutcracker syndrome. I checked postural variation of Nutcracker and found left renal vein compression is well relieved in left lateral decubitus and explained it to the patient. His usual sleeping posture was flat supine, and I recommended left lateral decubitus, and 1 week later, his flank pain disappeared. I would like to finish this talk by answering these 3 questions I raised in the first part of this talk. How common are these phenomena and syndrome? Now we are sure that they are much more common than they have been known. how important is the diagnosis to the patients? Very important to the patients physically and psychologically. How much we know about it, as is very little has been investigated and too much has been neglected. So I strongly recommend people doing abdominal ultrasound or CT to pay some attention to the left renal vein. It might be a big help to the Nutcracker patients. Thank you for joining this talk. And if you have any questions or comments, please email me. And when you have time, please visit my educational website. Thank you.